Thanks, everybody. I appreciate you showing up. This is a big subject, and it really affects all of us sometime in our lives. As far as objectives, we want to talk a little bit about definitions of what diarrhea is. We want to talk about the impact of diarrhea, and then we'll focus on acute and then chronic diarrhea. We could spend a whole semester going through this. I don't think anybody wants that, but we'll really try to touch on major subjects of both of these entities. And then I'm happy to answer any specific questions at the end. So as far as definitions, from a perspective of pathophysiology and what truly is diarrhea, objectively, anything that's 200 grams of stool per day is really considered diarrhea. Most of us really don't look at it that way. Most of us look at it this way, and that is excessive amounts of stools at least 3 times per day in a 24-hour period, of course, with a change in consistency and form. Now, this is based on a study that was done in the 70s of what was normal. They took 2,500 people and they looked at what's normal in life, and it can be any. Normal is anywhere from 1 bowel movement every 3 days to less than 3 times a day. So as far as definitions, this will help us move through. We're going to really focus on acute diarrhea, and then we'll focus on chronic diarrhea. We're really not going to spend any time on persistent diarrhea per se, but acute diarrhea is anything less than 14 days. That's acute. Persistence in the middle, of course, and then chronic is anything greater than 30 days. Dysentery is also an important thing to be aware of. This is when you experience fevers, blood. This is serious and definitely affects a lot of people. Now, the impact is significant. Just in the United States, there are about 179 million cases of diarrhea a year. And from a worldwide perspective, this is from the CDC, This affects a lot of children. About 2,200 kids die a day from diarrhea, so it has a big impact throughout the world. If you're less than 5 years old, in a lot of these impoverished countries, you're dealing with the second most leading cause of death in those countries, which is diarrhea. So it's not a small factor. I'm not going to do too much pathophysiology, even though I love it, but we're going to talk about how you develop diarrhea. So amazingly, most of us take about 2 liters of fluid in per day, orally or through the food. About 8 liters of fluid is made by the stomach, the pancreas, the biliary system, and so you get this 10-liter fluid delivery to the jejunum. Now, the jejunum is also, and ileum, these are the parts of the small intestine. It does a great job of absorbing most of that, okay? So you're only left with about 1.5 liters of fluid as it hits the colon. And then the colon absorbs the majority, and you only have about 100 cc's in the stool of all of that. So if people who don't know what 10 liters is from a metric point of view, that's about 2.6 gallons of fluid a day that's moving through your GI tract, and you're only putting about 100 cc's out. And so any abnormality that affects absorption or secretion, even just by 1%, is enough to cause diarrhea. So it's an amazing system, the GI tract, to be able to deal with this. As far as acute diarrhea, we're going to focus on this. Overwhelmingly, the most common cause of acute diarrhea in the United States is infectious. And these are typically viral, and we'll spend some more time on specifically norovirus, which we all face. There's about 21 million cases of norovirus in the United States. Rotavirus, especially with kids, there's a vaccine now for rotavirus, and so that's decreasing, but can make people quite sick. And then the bacterial infections that we see a lot of in the United States, especially C. diff, E. coli, Salmonella, Campylobacter. Parasitic infections, we don't see a lot of those. Giardia is one, certainly. People who have been in Salt Lake for a while. Cryptosporidium, I don't know if you remember the pool situation about 7 years ago. There were several hundred people who got Cryptosporidium swimming in recreational pools. So it can happen. Entamoeba is a parasite that we see in Mexico a lot. I'm not going to spend too much time on non-infectious etiologies of acute and infectious diarrhea, but it certainly happens, usually medication-induced. And you can also develop something called ischemic colitis, which is really important. The most common cause of lower GI bleeding in individuals over the age of 50 that causes pain is ischemic colitis. It's not to be ignored at all. So, as I said, the most acute diarrheas are minor. They go away on their own. You don't really have to do anything. But there are some things you need to be aware of that can lead to concern and a need to really focus on aggressive evaluation. Dehydration, fevers, bloody diarrhea, anything persisting greater than 48 hours. We talked about abdominal pain and then recent antibiotic use. So the American College of Gastroenterology put this slide out. It's too busy. I'm not going to really focus on all of it. But what it does to help us, to help you, is it helps break down these thousands of causes of diarrhea so that we can focus on watery diarrhea or bloody diarrhea in the acute setting. One thing to note is that if you've traveled and you experience watery diarrhea or bloody diarrhea, then typically we'll use empiric therapy for that. That means we'll go ahead and just put you on antibiotic therapy. And we'll show, because of travel outside the United States, the most common cause of an infectious process is not viral, but bacterial. Here in the United States, by far, viral etiology, viral cause is the most common. But when you leave the United States, bacterial is a major culprit. The other thing to mention is, as they pointed out, mild diarrhea, we don't really do much about. We just focus on hydration. And then people have persistent diarrhea who kind of fall in the middle of this. This has really changed quite a bit as far as evaluation. We use this multiplex PCR testing, okay? So this, in the past, when I was going through training, if you had diarrhea, you'd do stool cultures. You'd wait 7 to 14 days, wait for a result. That's changed. From some smart people, they use this evaluation called PCR, which analyzes and very quickly the presence of all of these different types of bacteria, viruses, and parasites. So we can get results in hours as opposed to weeks. There's something called BioFire. This is a fascinating company. It's here in the United States. It started here in Utah. It started in Idaho. BioFire is the diagnostics apparatus that we use. Intermountain Healthcare uses it. The University of Utah uses it. So it's a very eloquent way of evaluating for acute infectious causes. Now, treatments are not always bacterial antibiotics. So for mild disease, and I was talking to a microbiologist out here before we started, a lot of times you can just do oral rehydration therapy. So a cheap way of doing that is just to take some salt, some bicarbonate, some sugar, put it in water. If you don't want to do that, here's the mixture. But if you don't want to do that, Pedialyte, the World Health Organization, there are other different rehydration formulations that are available that you can get over the counter that can help with that. Probiotics, May had a great talk last week on probiotics. There's a lot of flux with respect to probiotics. If you've had antibiotics, there's a good indication to use probiotics also in irritable bowel syndrome, something called necrotizing enterocolitis, pouchitis, ulcerative colitis. But most of the time, probiotics aren't really that necessary in these acute settings. Bismuth or Pepto-Bismol is really an interesting thing. The salicylate portion of that actually helps with the diarrhea, and we'll talk about it can be used for prophylactic measures as well. Loperamide, which is Imodium, is safe in most situations. Okay, if you have an acute watery diarrhea, then Imodium can be quite useful, and we can talk a little bit more about this as well. As far as antibiotics, like I said, most of the time we don't use antibiotics. We use the multiplex BioFire to help direct us now, and we also, if there's a history of travel, then we'll use either Cipro or zithromycin. We're getting kind of away from zithromycin, Zithromax, Cipro, because there's a lot of resistance to that. Okay. Let's talk about foodborne infections. This is huge. We face this all the time. By far, the most common cause of foodborne illness in the United States is green leafy vegetables, everything that we're supposed to be eating. There's 48 million cases of it a year. As far as what causes this, the vast majority is norovirus. Okay, so 21 million cases of norovirus in the United States. Whoever's been on a cruise, they've been exposed to this most likely. We see this all the time. Long-term care facilities, it's huge. When my son played football in middle school, we went to a restaurant, which I won't mention because it's closed, but the entire football team, all the parents, all the coaches, and everyone at the restaurant got norovirus. And for anybody who's gotten it, it's miserable. Usually lasts 72 hours. The thing about norovirus, which is really unique, is there are all kinds of subspecies of norovirus. So if you're on a Disney cruise and you get norovirus and then you say, oh, I'm going on Norwegian next time, and you get it again, you have no immunity to most of the norovirus. You can still get it, and it can last up to 72 hours. It only takes 10 viruses to get it. It's a very fastidious virus, so it's not a pleasant thing to experience. This is a busy slide, but these are things you've probably seen or heard about over the last several years, certain bacteria that can lead to infections. So focusing on one of those, Listeria, Ben & Jerry's, you know, my favorite, 2 to 3 years ago, they had a whole batch of Listeria-infected ice cream cantaloupes. The real big one, and people probably remember this, the Shiga toxin E. coli with a jack-in-the-box infection when kids were dying of hemolytic uremic syndrome. This is a very serious infection, and a lot of people are using unpasteurized milk now and unpasteurized fruit juices, and that's a serious infection. Just one note about this particular bacteria, that's why you don't necessarily want to do antibiotics all the time, because this particular bacteria, if you give antibiotics, it increases the likelihood that you're going to get hemolytic uremic syndrome. So it's important to kind of follow these algorithms and not just knee reflex antibiotics. Okay. We talked about Cryptosporidium. This is an interesting one, Cyclospora, raspberries. So be careful of those. We're focused on traveler's diarrhea. We all have to travel. If you're in North America, Western Europe, you're going to be okay. But if you go to these places that are outlined by the CDC in red or yellow, you need to be very careful. As we talked about, viral infections, most common in the United States. As soon as you leave the United States, though, it's bacterial. And the most common is enterotoxigenic E. coli. It's not necessarily important to remember all these particular things. It's just important to know, usually viral in the United States, bacterial outside the United States. But you can see 90% bacterial and only 5 to 10% viral. This is put out by the American College of Gastroenterology. Prophylaxis, I'll just mention a little bit with traveler's diarrhea. Pepto-Bismol has been shown to be effective. Kind of tough to take. You got to take it 2 tablets 4 times a day the whole time you're there. So that's a difficult thing to do. We typically don't use probiotics for prophylactic therapy. And antibiotics, some locations around the world it's indicated, but the vast majority it's not. So let's focus on a few minutes chronic diarrhea. A lot of us get this. About 5% of the population experiences chronic diarrhea. And the way the American College of Gastroenterology really breaks this down to try to help elucidate the cause is to look at resource-rich settings like the United States and then resource-limited settings. In the United States, and May mentioned this last week, the most common cause, hands down, is a functional type of diarrhea, irritable bowel syndrome. Inflammatory bowel syndrome, we'll talk about these, is another form, but chronic infections are way down here. If you leave the United States into an area like Mexico, chronic infections are very common, parasitic infections. So, again, a busy slide. It's really meant to kind of show you the major categories of chronic diarrhea. And we divide it just like we do with acute. Watery diarrhea, bloody or inflammatory, and fatty. We talked a little bit before the lecture about certain types of things that can lead to chronic diarrhea. There's osmotic and secretory. So osmotic, if you're eating something and you're having diarrhea, that's almost certainly osmotic diarrhea. If you fast and it goes away, then that usually is osmotic diarrhea. If you're having 20, 30, 40 bowel movements a day, that's usually secretory diarrhea or some type of malabsorption. So if we look at the initial evaluation, this is much different than the acute diarrhea approach. Typically, we want to do a good history to see if there's been any radiation or anything that, or you've had your gallbladder out, these type of things that help delineate what could be going on. The American Gastroenterology Association just came out with a new recommendations of general testing, which was interesting. They do recommend Giardia as testing, which is kind of new. Giardia is a protozoan that happens a lot more than we think. But the additional testing can be significant. It can be endoscopy, colonoscopy, specialized testing, both in the stool and the blood. So the thing about chronic diarrhea is you can usually figure out what the cause is, but it takes a lot more of the evaluation of the algorithm to figure that out. As we mentioned, the most common cause is irritable bowel syndrome. This is a functional type of diarrhea. Every 4 years, a bunch of gastroenterologists that are high up in the college go to Rome for a month and come up with the Rome criteria. It's a pretty sweet deal if you're a part of that. And then medication, again, this is meant to be a busy slide because there are literally hundreds, if not thousands, of medications that can cause chronic diarrhea. Things like metformin, which a lot of individuals are on. We talked about malabsorption before the lecture. This, again, is a very common cause of diarrhea. These involve food allergies, celiac, sprue, lactase deficiency if you have difficulty with dairy, chronic pancreatitis, bacterial overgrowth, and we won't focus too much on the specifics of those. Celiac disease is a pretty common one. They genetically modified wheat in the 60s. So individuals that are exposed to gluten can develop an inflammatory process that causes the absorbing components of the small intestine called the villi to denude. They become atrophic, and you can develop abdominal pain, bloating, diarrhea, weight loss, skin disorders, all kinds of problems associated with celiac. And if you want to talk about more of the pathophysiology, we can discuss that as well. Microscopic colitis, that person who's coming in with 10, 15, 20 bowel movements a day, day and night, this is a very common cause. It's not clear exactly what causes this. It has been associated with proton pump inhibitors, things like omeprazole, Protonix, things of that nature. Serotonin reuptake inhibitors, which are used for depression, and non-steroidals. But you can get two types. This is diagnosed by colonoscopy. You remember we talked about different ways of approaching diarrhea, and colonoscopy often becomes an important tool to assess this. This is very fixable, very easy to treat if you delineate the cause. Inflammatory bowel disease, of course, is a very common thing. So if you're having watery, bloody diarrhea, abdominal pain, you really need to think of Crohn's disease, ulcerative colitis, and that can be determined based on colonoscopic evaluation. I won't spend too much time on this as far as infectious processes, but certainly as the American Gastroenterology Association has pointed out Giardia can be a very common cause of chronic diarrhea, as can C. diff, which has really taken off since 2000. You guys have probably heard about this. People who take antibiotics, they alter their flora, and then you set up shop for these virulent strains of C. difficile. You can get very sick. It can range from mild disease to fulminant disease requiring that you have a colectomy, have your colon out. People are dying from this. This is a serious thing. The treatment really focuses on finding the diagnosis. Chronic diarrhea, you can, the vast majority of times, you can delineate what the diagnosis is and then effectively treat. And that's what we really try to do, methodically figure this out. And that's it. So if you have to deal with this guy, then we're around the corner to take care of you. So, so any questions? Is that yes, sir? So it's a good question. I mean, one of the things about chronic diarrhea is that there's so much variability in physiology. And so if your physician feels like that's a worthwhile thing to try, then I would definitely follow his or her advice to try that. But often, once you've developed that, you really need to find an alternative because it usually comes back. Lactase deficiency is fairly common in the United States, and certainly people who experience significant infections can often lose that enzyme. As far as Lactaid, it works for some people, so it's all a trial and error. There was an article published in the New England Journal of Medicine in 1999 that looked at trying to quantitate what you could tolerate as far as milk products, and it ends up for most people being about a quarter of a glass of milk. But everybody again is different. You just have to try it. You can try lactate. You can try the lactase, but it won't hurt you. Yeah, some people do okay. A lot don't. So my advice is to go ahead and try it and see what happens. So. Couple things to consider. I mean, by far, norovirus is the most common, so there's not much you can do. You can. We talked about bismuth as being an option. The best thing that you can do is just really be diligent with hygiene. So that's the best thing. They're actually, just like rotavirus, they're looking at developing a vaccine for norovirus, but it's difficult because there's hundreds of, if not thousands, of subspecies of norovirus. You know, I would talk to your physician. It definitely works. The subsalicylate portion of Pepto-Bismol is effective, but it's hard for people to take because you're taking 8 pills a day. The whole time you're there, it turns your stool black. Sometimes what you can do, because in Mexico, enterotoxigenic E. coli is the most common thing. Sometimes you can talk to your physician about, hey, I'm going there. Could I have just 1 dose of zithromycin to have in case something happens? Okay, so that's worth. But if you're going to the Four Seasons in Mexico, that's probably not going to happen. So, so hopefully you're going there. So. As far as the gallbladder, about 15% of people that have their gallbladder removed will develop what's called a bile acid secretory diarrhea. So the gallbladder acts as a reservoir. It holds the bile in. But once you remove that, the bile is continuously secreted by the liver. And as it gets on the intestine wall, the mucosa, it can cause secretion of fluids. And some people can develop a bile acid secretory diarrhea. That's easily treated with something called a sequestrant that binds the bile and takes care of it. So irritable bowel syndrome is a functional disorder, okay? There are no biological markers for irritable bowel syndrome, meaning when you do a colonoscopy, it's normal. When you do blood work, it's normal. There are no abnormalities on radiographic exams, okay? It's based on clinical criteria that they develop in Rome about every 4 years. Inflammatory bowel disease is much different. Inflammatory bowel disease is, in fact, an inflammatory process of the intestines. If it's Crohn's disease, it can occur anywhere from the oral pharyngeal area all the way down to the anal region. Ulcerative colitis is isolated to the colon. So that people get very sick. So that's the difference. Yeah. Yeah, so C. diff is tough. So they did the right thing. The mild cases of C. diff, they initially treat with vancomycin or fidaxomicin. Have you had it before, or did they just start you on the taper? It's usually, yeah, because you've had a taper. So you're on your second. You could be on your second recurrence if you're not. If things progress for you. You could be on your third recurrence, and in that situation, then fecal transplant it would be an option for you if you end up having recurrence. Okay, so that's a really interesting thing. FMT is something that has been going on for the last 7 or 8 years, where they'll actually take stool and you implant it into the colon, and it helps with the flora to get rid of the C. diff. They've used FMT on everything now. They've used it on autism, ulcerative colitis, Crohn's disease, obesity, all kinds of things. But the indication definitely for C. diff, if you have recurrence, that's something to consider. Yeah, we had talked about that before the talk, definitely. We see a lot of food allergies, and not only just diarrhea, it can cause something called eosinophilic esophagitis and other things. So a lot of allergies, it's trial and error to figure out what you're allergic to, and it's not always clear right off. There's so many different food products that you're exposed to, but yes, they can definitely cause that osmotic diarrhea we were talking about. So, yeah, definitely. Yeah, so these are forms of microscopic colitis. There's lymphocytic colitis, where you have this infiltration of lymphocytes, and there's collagenous colitis, where you get this deposition of collagen along the layer of the colon, and they cause secretory diarrhea. So one thing that you can do that's very effective, there are other therapies, but most of us use something called budesonide, which is a form of a steroid that gets rid of the inflammation. And it's very effective. There's a immunologic is probably better than autoimmune because it is induced by an agent, but it can be treated. The vast majority of people don't need to be on budesonide a long time, usually a month or two, and it can get rid of it. There are all kinds of things. Is this antibiotic induced? Are you having overflow diarrhea because they're giving you pain medication that's causing what we call obstipation or chronic constipation, and so the stool liquefies? So I would say, chronic diarrhea is common. It affects 5% of us on a regular basis, but you need to elucidate or determine the cause. That's another component that it could be. Certainly, that would the non-steroidal could be causing microscopic colitis, and then if you're able to get off the non-steroidal and treat the microscopic colitis with budesonide, you should get better. They've definitely done chronic studies on loperamide. The way loperamide or Imodium works is it actually increases the contraction, so it slows the motility down. In doing so, it promotes absorption of fluid and decreases secretion. So the dosing in the GI literature, you can use up to 8 tablets or 16 milligrams a day. Long term. Not advocating that. It is safe in that situation. Rarely, if you have any type of neurologic problem or cardiac problem, then we usually try to avoid that. You don't want to be using it in dysentery, this bloody type of, but irritable bowel, if that works for you, it's safe and safe to use. You always want to titrate to the lowest dose you can. So bananas, rice, applesauce, and toast, yeah, just really bland. So if you're having an acute infectious diarrhea, you want to focus on rehydration and real bland diet. You don't want to go to, and have a real rich, ultra-processed diet, because that can cause a lot of bloating and diarrhea in itself. Yeah, so omeprazole is really interesting. It's and even though it can cause microscopic colitis, it's a very safe medication. Over the last 5 years, you've probably seen the fact that there was concern with Alzheimer's, heart disease, stroke, kidney disease. There's a great article by Saltzman in September of this year in the Journal of Gastroenterology, where they looked at all the data for the last 25 years for omeprazole, and it's safe. It can cause, there is a slight risk of C. diff, there is a slight risk of microscopic colitis. There is no risk of osteoporosis, okay? They've done DEXA scans to look at that, and it doesn't cause osteoporosis. It can increase risk of fracture later in life, but it does not cause osteopenia and osteoporosis. The bottom line with any medication, and omeprazole is to be considered that as well, you always want to titrate. If you don't need it, don't take it. There are a lot of people on omeprazole who really don't need to be on it. And if you need to be on it, always titrate to the lowest level. But the bottom line is, and we've been dealing with this for the last 5 years until the Saltzman article that came out, but it's safe if you need it. So everything's a balance. So it depends. So if you have a frank allergy, like we're talking about with eosinophilic esophagitis, the recommendation is 4 to 6 weeks to stay off and then re-challenge. Most things like dairy, we were talking about lactase deficiency, a couple weeks is enough to figure it out. So probably the answer is anywhere from 2 to 6 weeks.
To stay off.
And then re-challenge. Retake it and see if it causes the same problem. Psyllium Metamucil is often used, and it's great for most people. It's psyllium. It's both soluble and insoluble fiber. It's from a plant called Plantago, and so it really helps with bulking. We talked about that physiologic slide, where you have 2.6 liters of fluid coming through your GI tract every day. Your GI tract's able to pull most of that out. But if you're 1% off, you can start developing diarrhea. So fiber's great as a bulking agent and is really a good option. You can do it through your diet. And May was talking about this. Diet's super important for probiotics. You're much better to do it in a healthy way, but Psyllium Metamucil is a good adjunct to that with chronic diarrhea. Yeah, and Citracil is fine. A lot of people will get bloating with, not a lot, but a few will get bloating with Metamucil, and Citracil or Benefiber is an option for you. So it depends, like I said, that not everything fits right into where you need to. Is it acute diarrhea? Is there fever? Is there bleeding? So Metamucil is great for kind of a chronic diarrhea, loose stool, those type of things.
Just if you take it like once?
You typically need to take it daily. If you were here with Dr. Heiner's lecture, he would tell you to take it till the rest of your life, to the day you die. Daily, tablespoon, 1 to 2 tablespoons a day for the rest of your life. Well, great questions. Thank you, guys. I appreciate you being here. Thanks.